Pleasant good morning to everyone. Today we have come to the final day of the workshop. Today we'll be doing on MRI. So we have a very interesting blend of topics today. So firstly we'll be starting with MRI brain, a radiologist perspective by Dr. Niriksha Shetty. Then following that we have MR Abdomen Imaging by Mr. Manzoor Ali. Followed by we have functional MRI by Mr. Mohammad Siad. So first we'll start with the MRI brain, a radiologist perspective by Dr. Niriksha Shetty. Over to you, ma'am.
Hello, good morning. Am I audible?
Yes, ma'am.
Good morning, everyone. So here we are on the last day of the workshop for the radiology day workshops that we are having for 3 days. So you have had 2 days of good informative talks on various topics. I think you have covered HRCT lungs, stress radiography, CT abdomen protocols and sequences and all those interesting topics. Today, I'll be talking to you a very general topic, a basic perspective of MRI brain. Some things about the sequences that we're going to cover, basic sequences that we're going to cover in MRI brain, the difference between the sequences, very minimal of the physics that I'm going to touch up, just brush up on the physics because I'm sure you guys know physics of MRI better than I do as of now. So, and the two very important pathologies that we get in our emergency setup. Okay, let's go ahead, start with it. Okay, so introduction. So what do we know about MRI? MRI is, as of now, is the most sensitive modality for most of the intracranial or CNS pathologies, I can say, brain, spinal cord including, but as of now, with the 3 Tesla MRI and with an extensive advancement, the whole body imaging is been possible with MRI with a very good specificity and sensitivity. So MRI is an imaging modality that uses non-ionizing radiation. That is what makes it the most suitable choice of investigation for most of the pathologies to create useful diagnostic images. Unlike CT and X-rays, we use non-ionizing radiation here. So MRI pulse sequences is a programmed set of changing magnetic gradients. As I said, we're not getting into the deeper physics, but we know there are multiple parameters in MRI. That is, you have your echo time, repetition time, flip angle, then you have the matrix size and all that, and diffusion weighting. Multiple sequences are grouped together into a MRI protocol. So we have protocols specific for each pathology or for each anatomical structure. So whatever you want to see, I'll come to it. What is an ideal protocol? How do you tailor an ideal protocol? So different combination of these parameters affect the tissue contrast and spatial resolution. NMR, nothing but the nuclear magnetic resonance, discovered just after the end of the Second World War. We're not getting into the depth of the history either. So MRI principle, MRI is based on the principle of nuclear magnetic resonance. Two basic principles is that atoms with an odd number of protons or neutrons have a spin, and a moving electric charge, be it be positive or negative, it always produces a magnetic field. So body has many such atoms that can act as a good MR nuclei, but the one which we use the most is the hydrogen, because our body, we all know, is made up of 70% of water, so which contains abundance of hydrogen, and we use that for our MR imaging. So hydrogen nuclei is one of them, which is not only positively charged. We know hydrogen do not have neutrons. It has a proton and a single electron spinning. So it is positively charged, but it also have a good magnetic spin. MRI utilizes this magnetic spin property of protons of hydrogen to elicit images. Telling in simpler term, what are we doing in MRI? Basically, in our body, we have lot of these hydrogen nuclei, which are positively charged, which are randomly arranged. We know that they are randomly arranged, having a full-blown Brownian moment, very randomly arranged in the body. So when you subject it, they all, this spinning electrons, as I said, has a magnetic field. So when you subject it to a very high magnetic field, all these protons will align. They will all align in one particular direction. You know, there is something called longitudinal alignment, and then there is something called transverse alignment. Okay, so they align in one particular direction. The low energy one will be along the magnetic field, and the high energy one will be against or in opposite the direction to the magnetic field that we are applying. So once you align them in a particular direction or a single direction, then you give the radio frequency. So RF frequencies you give. So you basically disturb that alignment, the one which you have aligned. So you disturb them. Then when the radio frequency is taken away, they come back. That is called relaxation. These protons come back to their relaxation phase. While they do that, they emit some signals. Those are the signals that we are taking up in our RF coils, and then we are imaging it in our system. That is how we get an image. This is our basic principle. Okay. Ahead. So MRI, it produces 2D images. It was all, this is a history again. Human images were formed in a year later, that is in 1977. So MRI scanner, you know, has a powerful magnet. Now we have around 1.5 Tesla to 3 Tesla. That is what it is. It is disproportionately huge to the Earth's magnetic field. It is enough to, I know you guys might have heard this, it is enough to lift a car up. That is the strength of the magnetic field that we are providing. So there's a powerful magnet in which the patient lies. Then there is a radio wave antenna, as I said, to send the signals to the body, then to receive the signals back. These are the radio frequency signals, RF signals that are going to disturb the alignment that I was talking about. Then these returning signals are converted into images by a computer attached to the scanner. Imaging of any part of the body can be obtained in any plane. We have our classic axial, sagittal, and coronal images. TR and TE, again, you know what it is, repetition time and echo time. Repetition time is nothing but the time between these two excitation, and echo time is measured after a radio frequency. That signals what you get, time interval in which the signals are measured after the RF excitation. So in general, you need to know about the two conventional sequences, that is T1 and T2 sequences. T1, you have short TR, short TE. Remember that. T2 is long TR, long TE. The range, you know, that is 1000, here 45, there is 2000 and more than 45. Okay, just remember these two conventional sequences. Any other sequences that we have made, we build upon these only, these two conventional sequences. Okay. So not the modern one. Now we have extreme sequences, very advanced sequences that we have in MR, but these are our basic sequences, right? So proton density imaging, we'll talk about it later. Now this proton density imaging is, it's mainly coming into picture only in most of the MSK cases because FLAIR has taken over all the applications in MRI brain, right? So why MRI? As I said, nothing new, no ionizing radiation. You can acquire in multiple planes. It has excellent soft tissue contrast, and angiographic images can be obtained without giving a contrast. Advanced techniques we have like diffusion spectroscopy and perfusion, which allows us for a precise tissue characterization. So functional MRI, we have our next talk on functional MRI. It allows visualization of both active parts of the brain during the certain activities, and risk of identity contrast allergy is very elevated. It is less. Disadvantage, the main disadvantage that we have, it is an expensive modality, and the availability. Most of the places we still do not have an MRI. So the scan time is longer, and claustrophobia, that also is a very main disadvantage that we have. Okay, so it is subject to many artifacts, metal implants, pacemakers, and foreign bodies, and MRI contrast possesses risk, as we know. So let's try to simplify this more. These are the terminologies that we are going to use henceforth, and you all know this terminology, but try to really keep it simple in your head. Whatever, in the end of my talk, I want all of you all to just, when you are in the AR duty or in the duty for your night calls and all that stuff, I just want you all to look at something, you know that something is wrong and what it could possibly be. If there is something you can do, or if the doctor can intervene immediately, that you should be able to do if you do not have somebody near you, if you do not have an emergency consultant or a radiologist. At least you should be able to tell the basic pathologies that you see in your day-to-day practice. And if you see something, what is an extra sequence that you have to put if you do not have anybody to tell around you, because patient shifting again back forth is a cumbersome job again. So you should be able to assess to the very minimal extent at least what more you might want to do with this, right? So high signal, you know the terms that we use in MRI. It is hyperintense, hypointense, and isointense. Hyperintense is high signal intensity. It is nothing but white, and intermediate signal intensity, that isointense, is gray, and low signal intensity, hypointense, that is called hypointense, that is black. So you have white to black, gray in between. There are n number of shades of gray, but we'll just simplify to keep it as gray, is intermediate signal intensity. Okay. Variety of sequences, and just put the names of sequences that we have. You have T1, T2, post-gadolinium, T1 weighted images, FLAIR, still sequences, diffusion weighted sequences, ADC imaging. You have gradient echo sequences, susceptibility weighted images, proton density images. Then you have the specialized sequences like MRS, MR angio, MR pinography, MR perfusion, diffusion tensor imaging, and PET scanning. Let's not touch upon these per se. Each modality itself is a talk for you all, so we are not going to get into each one of them. All right, here this is, by the end of this talk, get accustomed to the normal T1, T2, and FLAIR diffusion sequences, at least just how they look. There's a very first slide, don't worry about it. The first one is the CT image, there you have. Then you have the T1, T2, FLAIR, proton density, and gradient sequences. Ignore the other three. Just look at the T1 and T2 images. My cursor is visible? T1. So T1 and T2 images, right? So what is the concept that we have normally? T2, bright, water is bright in T2, or CSF is bright in T2, low in T1. Okay, just keep that concept in your mind. That is okay. You have bright CSF in T2, dark CSF in T1, right? One more thing that you need to know, because there is FLAIR sequence, right? Where you're nothing, it is a T2 sequence where you're just suppressing the fluid. So How will you differentiate from T1 and flare? Sometimes you will end up getting confused between T1 and flare sequences. Just remember, in T1, you see here, gray matter is gray, white matter is white. Just remember that gray matter is gray in T1, white matter is white in T1. Okay. Whereas in flare, you have gray matter, which is more brighter, and white matter is darker. So you have to see that differences, because if you just see CSF, you will get confused between T1 and flare, right? To tell which sequence T1 and T2, look at the CSF, you know T2, done. Now if it's T1 or flare, just look at the gray matter and white matter. Gray is gray, white is white in T1. Flare, it is other way around. Don't get more confused. Just remember these 3 points. Okay. Now you at least will tell which sequence is which. Okay. Coming to our basic conventional T1 and T2 sequences. As I said, T1 is short TR, short TE, and T2 is long TR and long TE. Right? Here. This is just again for you to get accustomed to T1 and T2 weighted images. You have MR T1 weighted images here and T2 here. As I said, T1 and flare, just see there up to down. I put both images top and bottom. Both CSF is dark, but you see the gray white matter difference here. You will catch it. Okay. Then T1 is mainly for our anatomical details. Anatomical details you will see properly. Then I'll tell you what looks bright on T1 and all that stuff. Okay. So these 2 slides, try to remember. Dark on T1 is not of a big significance because most of the things are dark on T1. But bright on T1 is what you need to remember. What are the things that are bright on T1? Fat. Fat is bright on T1, so it is used for all these fat containing tumors, okay, malignancies. So that will be helpful. So fat, then you have your subacute hemorrhage. Okay, that is also important. Subacute hemorrhage. Then you have melanin containing, again, melanin is important. Melanin containing tumors or sometimes these calcifications also can be seen, right? Protein rich fluid, slow flowing blood, and paramagnetic substances like gadolinium, copper, and manganese. Gadolinium, that's why we use T1 contrast, right? So we have these structures that are bright on T1. Remember this: fat, melanin, subacute hemorrhage, and paramagnetic substances, right? If you go back, what is dark on T1? As I said, most of the things are dark on T1. That is why we can't differentiate it. So in cases of infarct, we'll come to stroke again separately. So edema, tumor, infection, inflammation, and hemorrhage in any other stages, low proton density, calcification, and flow void, all these are dark on T1. Not going to give you any much of added information from T1, right? Right. See, this is just a CT image I'm showing you here. But you can see something bright. You by now you know there is something wrong. You just see the CT, you know something is wrong, right? So there is this huge bleed here. There's a huge intraparenchymal hemorrhage here on the left cerebral hemisphere. Surrounding that you have edema. Surrounding that you have this hypodense region, hyperdense and a hypodense region. You can see the significant mass effect there. Remember always, mass effect is something really bad. So you have something big compressing on things, and that is when your symmetry comes to play. Look at both sides of the cerebral hemisphere. You see if they are symmetrical. They are not. That means here in this case, the mass effect is quite evident. But sometimes you will have very subtle effacement of lateral ventricles or something in some acute hemorrhages. That time it becomes a little important, right? So you have hemorrhage and surrounding hyperdensity causing significant mass effect. Now you know it is a bleed, right? Now what happens in T1? I told you. See how it is bright, right? So hyperacute hemorrhage will be bright on T1. Okay, now again, how do you differentiate this from your flare sequence? Now, imagine only this is given. Now you have to say if this is flare or T1. that is, see that gray and white. Gray is gray, white matter is white on T1 weighted. So it is really bright. So you have your hemorrhage here, subacute hemorrhage here. Then all this edema, as I said, edema will be dark, inflammation will all be dark. This is important, right? Okay. Now this I will be putting in all the basic sequences. Okay. So 4 shades of gray. Remember, only 4 shades of gray. Black. What do you see? Black. See the image that is corresponding here. There is black. That just means that there is no excited protons, no protons at all. So where does it happen? In air, in air and in dense calcification and cortical bones. See this? Really dark. I mean, really black. We use the term black. Dark we use for the term CSF. Okay, fluid is dark here. And then you have intermediate. For everything, intermediate shade of gray is for your brain tissue. That is gray matter and white matter that comes in between. White is your fat, gadolinium and methemoglobin. Right? That is bright. I told you in hemorrhage and all that you have your methemoglobin. Then fat. That is what is important. Bright structures. Right? Now coming to T2. The same list, 2 list, which is dark on T1, which is dark on T2 and bright on T2. Okay, 2 things. Now again, we'll first go into the things that are bright on T2. Edema, tumor, infection, inflammation, all those things that I told you are dark on T1 are now bright on T2. You can see it well, you can differentiate it well. That is why T2 is your preferred sequence. Nothing but here your cytotoxic edema that comes into picture. That is the pathophysiology behind it. I'll just talk about it in brief about the pathophysiology when I talk about the stroke pathophysiology. Okay, so edema, tumor, infection, inflammation, subdural collections, and in late subacute hemorrhage, all these things are bright in T2, right? Whereas calcifications, fibrous tissues, and paramagnetic substances, protein-rich fluid, and slow voids are all dark on T2. Just remember one list that is of T1, then the exact opposite you can write for the T2. Okay, this is again the 4 shades of gray. Air and dense calcifications are always, calvarium is always black because there is no excited protons there. Okay, so dark, you have protein bound water tissues that are dark here, and intermittent, you have the brain tissue, white matter and gray matter. White, you have the free moving water follicles, fat and oxyhemoglobin. Okay. Right, here I've just put 3 sequences for you to differentiate. Okay. See the CSF, it is dark, whereas in T2 it is brighter. Flare fluid is just suppressed. It is nothing but T2 image with suppressed fluid. Not stressing on again the gray matter, white matter difference. You see the cortical bone is dark in all of them. Okay, and gray white matter is intermediate gray. Right. Which scan best defines the abnormality? That again depends on the pathology. So each sequence is important. Never give a pathology or never come to a final diagnosis with one sequence because all sequences is important. Each of them complement each other. So T1 images, subacute hemorrhage, fat containing structures and anatomical details. Wherever you want to see these, that is when T1 weighted imaging becomes important. Fat containing structures like in fat containing tumors, it becomes important, lipomas and all those things, subacute hemorrhage. And for a clear anatomical details, T1 images are the best. So you have to always correlate or look into the requisition. This is when the clinical details becomes important. Look into the requisition. Sometimes if you do not have any radiologists around to ask them which are the sequences that you're supposed to put, just look into it. See what they want to look, what the clinicians want to see. Based on that, you can tailor your protocol. Okay. T2 weighted images, if you want to see edema, demyelination, infarction, and chronic hemorrhages. Flare images also again fluid suppressed to see edema, demyelination images, infarctions, especially in the periventricular. This flare images is very important in our multiple sclerosis imaging, right? Coming to these two special sequences, not special sequences, now it is routinely used, but these are the sequences that are derived out of our basic convention sequences, flare and stage sequences. Two important clinical implications of this inversion recovery concept are short-term inversion recovery and fluid attenuation inversion recovery. Right. So flare, I'll be talking about flare today because brain imaging mainly is the sequence we use as a flare. First described in 1992 and has become one of the cornerstones of brain MR imaging protocols today. A sequence with a long TR and T and an inversion time that is tailored to nullify the signals from the CSF. So what do you understand by this? It's T2, you're just nullifying the CSF signals, right? In contrast to the real image reconstruction, negative signals are recorded as positive signals of the same strength so that the nullified tissue remains dark and all other tissues have higher signal intensity, right? So nothing else changes, only the fluid is CSF is suppressed. Most pathological processes show an increased signal intensity on T2 weighted images and conspicuity of lesions that are located close to the interface between the brain parenchyma and CSF. This happens because in the periventricular regions, especially, you can't differentiate any bright lesions. If you have a very high signal intensity lesions, most of it are bright, I told you, right? Edema and all this, you cannot differentiate. That is when flare comes into picture, gives you a good contrast. Okay. Basic sequence, again, this is that shades that I was talking about. Now in flare, 4 shades of gray. Here, just remember, fluid is suppressed. So black and dark, whatever it is, that is your free water. The intermittent, you have the brain tissue, white matter and gray matter. Then the white, you have T2 bright tissue. Whatever it is bright on T2 is bright here also, except for the CSF, which is not a free water. You have nullified the signals from that. Right? Just images showing T1 flare and T2 flare images. T1 flare we do not use routinely. All we use, what we use routinely is T2 flare. Okay. Clinical implications. It is used to evaluate. I'm going to go a little faster. I think my time is up almost. It is used to evaluate diseases affecting the brain parenchyma neighboring the CSF containing spaces. It is mainly used in demyelinating disorders, as I said. Okay, and it is less sensitive to the lesions involving brainstem and cerebellum. Helpful in evaluations of neonatal and perinatal ischemic insult and in gliomatous cerebral. Forget all this. Okay, we didn't worry so much about it. So embolic infarct, that is where it comes into picture of flare images. It has an improved visualization. Chronic infarcts are typically dark with a rim of high signal intensity. This is important just to differentiate from an acute from a chronic infarct. This is typically dark with a high rim of high signal intensity rim. Okay. That high signal intensity rim is nothing but gliosis. This just shows the gliosis, which is well seen in flare and may be used to distinguish between old infarcts like that, right? That's what we're trying to show, this bright, small lacunar infected areas. Coming to the hemorrhages, what is the significance of flare images in subacute hemorrhage? It surpasses even CT in the detection of subacute hemorrhages. So nowadays, they do, we can actually suggest flare images instead of if they are suspecting a SAH. Okay. Right. The availability of high CT angio now they don't do, but anyhow. Now I'll be talking about the one most important emergency that we get in our casualties, that is stroke. Next, our slides are on stroke. Just okay. Ischemia. So what happens? What is a stroke? It is nothing but a sudden onset of a persistent neurological deficit. So patient comes with a sudden focal onset like weakness. Your what you call the requisition will just show right-sided weakness or left-sided weakness for 1 day, 2 day, or a couple of hours. Okay, so this is the most asked this requisition for the MRI brain. Stroke is a very sudden onset neurological deficit, and most of the time, more than 70% of the time, it is due to a thromboembolic event. Okay. Thromboembolic event is nothing but you'll have some thrombus, big thrombus somewhere, mainly most of the time the source is from the cardia, or it can be some other paradoxical thrombosis and all that. Let's not get into detail. So that thrombus throwing an emboli, causing a block of a big vessel, big or any small end arteries or small, and causing a loss of supply, the oxygen supply to a small amount of a brain tissue. That is what is happening in stroke. Okay, ischemic stroke is the most common one. So timing becomes very important because there is something called not getting too much into the details of it. There's something called a penumbra and a core of the ischemia. So when there is a block of blood supply to a particular area of the brain, you have a core which is gone, which is dead or a dying tissue almost gone. Then surrounding that is something called a penumbra. That tissue, salvaging that tissue is your aim, because the dead tissue is gone now, you cannot do anything about it. But there is this surrounding tissue that you can salvage, which has a window period. Window period will take 3 to 6 hours, they say. So where you can actually salvage. So here, the most important, don't get into it. As I tell, the cerebral ischemic infarction is 80% of the cause. Rest you have non-traumatic causes, venous occlusions, and other causes. Pathophysiology, ignore the slide. Just remember, it is the cytotoxic edema. What happens? The sodium ATPase pump will fail. So you will have more influx of the water. The extracellular water will come into the cells, and the cells will swell up. The swollen cells now cannot diffuse properly, cannot move properly. That causes your cytotoxic edema. That is the pathophysiology behind all of your changes that you see in the stroke imaging, especially in the diffusion weighted imaging. Okay, remember this: cytotoxic edema, cells are swollen up, not able to move properly, right? Forget the rest of the things, but yeah, just remember this: normal cerebral blood flow is in the range of 50 to 55 ml per 100 grams of brain tissue. So as soon as there is an arterial occlusion, the neuronal electrical activity will cease within few seconds. Okay. The loss of function due to ischemia can be reversible and is directly related to the level at which the blood flow is dropped and also to the time. Okay. This is all the cytotoxic edema. This picture, just see, this core that you see is dead or dying tissue. This orange area, what we are seeing, is the area where you want to, this is the area of you're aiming at to try to salvage by thrombolysis or any active intervention. So, while choosing any, what you call, modality or before imaging, what are the main 4 must-know questions in an acute stroke triage of a patient is there an intracranial hemorrhage that can mimic stroke? I'll tell you why that it becomes important. Intracranial hemorrhage means what? There is a bleed, right? What is the meaning of infarct? Something is occluded. So something is occluded, a vessel is occluded. So you just don't want your clinician or your neurologist to administer a antithrombolytic agents, right? You don't want them to anticoagulants, you don't want them to give them anticoagulants. What will happen if you give them anticoagulants? If there is an hemorrhage, the patient will bleed further. So you are making the situation worse. So you have to tell them if there is a bleed already. So intracranial hemorrhage, you need to know. And you want to see if a large vessel is occluded, you can do an active intervention. And then which part of the brain is injured, and if it is irreversibly injured, and is an ischemic penumbra present? That is there anything to salvage or not, right? So when someone asks you about a gold standard for imaging of stroke, your first answer has to be diffusion weighted imaging. Okay, it is the gold standard in stroke, gold standard sequence that you need in stroke. So diffusion weighted imaging, from that only you acquire a apparent diffusion coefficient. So Why am I stressing on diffusion weighted images? So the changes in diffusion weighted images is said to be seen is as early as around 2 hours, or at least before 6 hours you can see the changes in diffusion weighted images. As early as 2 hours you can start seeing changes in diffusion weighted imaging. So you can pick up the earliest, pick it up at the earliest. Then you need to know this. Flare, it is said it will take around 6 hours. More than 6 hours it will take for flare. Whereas in diffusion, it takes 2. I'm very sorry, I'm terribly sorry. Diffusion only takes 20 minutes. Okay? 20 minutes. Within 20 minutes of a tissue damage, we can see the difference in diffusion. Flare takes 6 hours. So now if you have a patient, you take, anyways, as the stroke protocol will be taking diffusion and your flare images. So you see changes in diffusion weighted images. That is, there is diffusion restriction, but you're not seeing changes in flare images. Okay, there is no one around. What are you supposed to infer out of this? So the ischemic event is between 20 minutes and 6 hours. So you still have that golden period, that window period where you can intervene. So you can tell your neurologist, you can go ahead and intervene because the event has occurred. It is a very hyperacute event that is less than 6 hours. That is why these two flare and diffusion sequences complement also, right? So the normal motion of water molecules within living tissues is very random. This is the basis of the diffusion weighted imaging. I told you they are Brownian movements, very random movements. Acute stroke, there is alteration of this hemostasis. So causes excess intracellular water accumulation will be there. Cytotoxic edema will be there. Then there is a decreased rate of water diffusion, right? And also just remember this, restriction of diffusion weighting, restriction in diffusion weighted imaging is not specific for stroke. That is why you need your ADC sequences. So you don't just see bright signal in diffusion, infer that it is an infarct. It could be something else. Look at the ADC sequence. If you have corresponding hypo intensity there, then that is more likely to be infarct than anything else. But if you do not see corresponding hypointensity, that is again a concept called T2 shine through. This diffusion weighted imaging has two properties. One is the diffusion wherever restriction. The other one is the T2 property, T2 imaging property. So that is T2 shine through. So that should alarm you that this is not an infarct. It could be something else like tumors or some other malignancies. And then you have to quickly put all your other sequences that you do for your malignancies and tumors and all that. Okay. Got the importance of these. So never view one sequence. View all the sequence, complement it with the other sequence and come to an inference. Okay. The first enough. So in diffusion weighted images, whatever is dark is a non-fluid restricted tissue. Intermittent and white is a fluid restricted tissue. Right. Corresponding ADC mapping. It is nothing but it is a measure of the diffusion. You just measure the magnitude of measure of the diffusion. So if you have corresponding hypointensity there, you have true fluid restriction. If there is no fluid, if it is not corresponding, that is T2 shine through. Not getting into the details of T2 shine through, it is a topic by itself. Okay. So leave this. I've been already telling about all this. So primary application of diffusion weighted imaging is stroke, early detection of ischemic stroke. There is the highly sensitive sequence. Okay. So the changes, this is with the time how it changes, very acute. And coming to one more thing, how do we divide actually? We have hyperacute stage, acute, subacute and chronic stages. Hyperacute, again, you have two early hyperacute and late hyperacute stroke. Within 2 hours, 2 to 6 hours almost, you say the hyperacute stage. Then acute is around up to 12 to 24 hours. Then up to 2 weeks and more than 2 weeks. Okay. This is how the progression of the stroke happens in diffusion weighted images. See that, just see the diffusion weighted images here. Bright they are, as the day goes by, the 30th day, it actually goes down at hypo. Whereas corresponding ADC sequences, you have hyper signal. That is nothing but the edema decreases, the diffusion gets better. That's all. The molecules, water molecules starts diffusing freely. Core of the infarct, as I said, is irreversible damage. Surrounding ischemic area may be salvaged. Okay. It is, what are the other areas where it comes into importance is that extraction marks lesions like arachnoid cyst and epidermoid cyst. That is important because in epidermoid cyst you have diffusion restriction, whereas arachnoid cyst you do not see any diffusion restriction here. And intracranial infections, pyogenic infections, encephalitis, all these areas you have diffusion restriction. Okay, Creutzfeldt-Jakob disease, trauma, and demyelination. ADC sequence, let's not get into a depth of it. As I said, it is nothing but magnitude of that diffusion restriction. Okay, lower ADCs are seen in the early ischemia. Estimating the lesion age and distinguishing between the acute, yeah, that becomes important to acute and subacute diffusion weighted lesion. As I told you, ADC gets brighter and brighter as the day passes. From hypo to hyper it goes, diffusion other way around. Okay. Other causes are there for non-ischemic causes for diffuse abscesses, lymphomas, multiple sclerosis, and seizures and metabolics like cannabis. Okay, this is a diffusion weighted imaging where you see the bright diffusion restriction. You can see in the right frontal hemisphere, you see a very territorial involvement, right? So this is likely an acute infarct. So corresponding ADC sequences show you a hypodense, hypointense area. This is a classical of an acute infarct. Various disease entities don't want, just remember acute stroke. Okay, high in diffusion weighted images, ADC will show low signal intensity. Okay, this is causes against cytotoxic edema. Other than stroke, in hyperacute, acute, and chronic stages, what are the other clinical uses? As I said, you can use it. It is used in malignancies. They also show restricted diffusion. Coming to gradient echo sequences, why are we talking about gradient echo sequences here? As I said, one other than infarct, what is another thing that you need to rule out in the, you need to look for in an emergency setup is bleed, nothing, hemorrhage. Okay. So gradient recalled echo sequences, they are exploited in detection of hemorrhage. Okay, that is basically there's a susceptibility weighted images, right? The susceptibility, where are we getting this magnetic susceptibility from in our in the blood? That is from the higher iron content of the heme. Here you're actually, unlike in CT, in MRI, you are detecting the secondary effects of this tissue for whatever is the insult, not the direct attenuation. Okay, remember that it's a secondary effect that you are detecting. Okay, as the iron in the hemoglobin becomes magnetized locally, produces its own magnetic field and thus defaces the spinning nuclei. Right? Understand this. The technique is particularly helpful for diagnostic hemorrhagic contusions such as those in the brain and in leave that PBS. So signaling susceptibility weighted image sequences, on the other hand, relatively immune from magnetic susceptibility artifact and also less sensitive in depicting hemorrhage and calcification. This is a flare image, whereas this is a gradient echo image where you have this blooming, right? We use the term blooming. So what are the pros? It's a very fast technique, but it is more sensitive to magnetic susceptibility artifact, and clinical use is only for, mostly for hemorrhage and calcifications. Right. Okay. This is a susceptibility weighted images you are having. You can see the multiple areas of blooming. Okay. Very sensitive for gradient echo MRC. It's very sensitive type. Susceptibility SWI sequences is the one which we do most commonly. most of the time in with the protocol for stroke. They have compounds that have paramagnetic, diamagnetic, and ferromagnetic properties all interact with the local magnetic field, and that results in the loss of signal. Then, okay. For micro bleeds and all that stuff, this is more sensitive. You have here actual flare image. You can see, right? Shows a large hematoma. This is a flare image. You're seeing this hyperintensity, and here you have a large hematoma with surrounding edema, and it is seen in the right subcortical white matter. You can see flare and T2-weighted images. Okay. There's also a small right convexity subdural hemorrhage. Here you can see subdural collection with hemorrhage. Okay, there are, while you did a susceptibility weighted images, here you are seeing multiple other microhemorrhages that you could not see on your flare and T2 weighted images. That is when your susceptibility weighted images comes into picture. I am not going to talk about MRI, MRP because I think you had a separate topic on cerebral angiography, but just want to emphasize on the fact that just to see if there is any involvement of the large vessels, we always include MRI angiography in cases of weakness, patient coming with weaknesses. You want to see if which vessel is occluded and where it is occluded, right? MRS, just touching upon MRS, not we do not have any much. MRS does not add on to any information that our normal sequences give, but also it is helpful in cases of tumors to differentiate the grades of tumors and all that. I just want you all to remember the normal metabolites. That's all. Okay. What does MRI does? It is a non-invasive physiological imaging of the brain that measures the relative levels of various tissue metabolite. It has wide clinical applications. Just when you see this peak, I want you all to, after today's talk, to know what that means. That's all. You have a myoinositol peak, that is a glial marker seen in many malignancies. Then you have the membrane marker, that is the choline peak. Then you have a creatinine peak, and then you have a glutamate peak and NAA peak, that is N-acetyl aspartate peak, which is a neuronal marker. Okay. It is nothing, the physics behind it is nothing that just that various electrons or various molecules will have their own spin of movement and will give out a little difference in signal will be there. We'll catch that signals and plot these graphs, and based on that, we come into some. This is the normal MR spectrum. So, lipids, they are nothing but products of brain destruction. Lactate signifies a product of anaerobic glycolysis. Na is a neuronal marker. Glutamine is a neurotransmitter. Creatinine is a metabolic marker, and choline is a cell membrane marker. Myoinositol, as I said, is a glial cell marker. Osmolyte hormonal receptor mechanism markers. Right. So observable metabolites that you have, just ignore these two columns. Just say lipids. You see it increase. When do you see a lipid peak, high lipid peak? That is cases of hypoxia, trauma, and high-grade neoplasm. Okay, this is important. Just see the first and the last column. Then you have a high lactate peak, again in hypoxia. This is what it's non-specific. You have many peaks. To remember, hypoxia, in stroke, in cases of tissue necrosis, mitochondrial diseases, neoplasia and seizure, again you have the lactate peak. Alanine peak you have in meningioma. This is a specific one. You have a high alanine peak in meningiomas. Acetate peaks you have in abscess and neoplasms again. Na in Canavan disease. This is important. Few specific ones you can remember, like as I said, alanine peak in meningiomas. Canavan disease, you have Na peak, because you have a neuronal loss there that causes a NAA peak. N-acetyl aspartate peak, as I said, what does it signify? It is a non-specific neuronal marker, but again, Canavan's disease, it is increased. Glutamine and GABA peaks you see in hypoxia, succinate peaks in brain abscess, and creatine peaks in trauma and hyperosmolar state. Choline peaks are again increased in neoplasias and myelinations. Then there is ratio. NA creat ratio, not getting into the depth of it, but you need to know we can have these values with you. NA and creat ratio should not be less than 1.6. NA choline ratio should not be less than 1.2. Okay. So this is a chart again. If you can remember, just briefing it or read through it again. In cases of malignancies, you have high ionistol and Na peak, choline Na peak will be there, decreased, and Na creat peak will be increased. Okay. Right. Let's skip these. So what are the clinical applications of MRS? MRS are mainly used in brain lesion. As I said, this glial tumors, it is able to differentiate between the different grades of tumors, high grade glial tumors or low grade glial tumors, distinguish neoplastic from non-neoplastic masses, primary from some metastatic diseases, tumor recurrences versus radiation necrosis. Even here, MRS plays a very important role. Prognostication of the disease and recognition for any biopsies, stereotypic biopsies, and monitoring the response of treatment. Okay. Diffusion, just a few slides about diffusion tensor imaging. That is nothing but to see your white matter tract. So red indicates the tracts that go from right to left. Green encodes anterior to posterior tracts. Blue denotes a superior to inferior tract orientation. Okay, what are the application? That is for any white matter tracts or white matter tumors, and in cases of children, for an immature brain to delineate the anatomy and pre-surgical planning. And important application is in Alzheimer's disease to detect the early diseases, also in MS for plaque detection. So MRI protocols, as I said, you put into many sequences into picture. Whatever is suitable for that particular pathology, you design a protocol. Okay. The radiologist tailor and the pulse sequence try the best answer of the clinical question posed by the referring physician. This is the main aim of the whole talk today. How do you tailor the sequences to answer the question that is needed for the physician? Okay, so your protocols should maximize the diagnostic quality, deliver of consistency in scan quality, and efficient and effective radiology service delivery. Standard protocol, you have T1 sagittal, T1 as I said for the anatomical overview, and for T2 axial, flare axial and diffusion weighted axial images you see, and T2 stir sequences. Strode protocol per se, as I spoke about, as I told you, I cannot stress more on the importance of the diffusion weighted images. It's more important, most important one. Just a brief thing, CT is the till date the first imaging modality that they will ask for a patient in cases of stroke, especially to rule out bleed. Okay. If a CT is not done, then you do a MRI. If a MRI is directly done and in susceptibility weighted images, as I told, if you see those blooming, then you can take a call on taking a CT cut to see the hemorrhages better. Okay. T1 axial, T2 axial, and you have the flare axial sequences. Okay. Diffusion weighted and ADC sequences and susceptibility. These are your stroke protocol. T1, T2, you have flare axial images. Diffusion weighted when you get ADC out of it, then susceptibility weighted and T2 axial images. This is for hemorrhage. And MR angio, you finish with an MR angio always. This is a very early sign. I'm just showing you what is called loss of flow void that you can see in an acute stroke. See, you see these flow voids, right? So you see the loss of flow void here. That means that is some embolus that is caused. This is a diffusion weighted imaging showing the hyper intensity with a very territorial hyper intensity. You can see causing this again is a typical of an acute stroke. Epilepsy protocol, I won't have time to get into it that much. Anyways, T1 epilepsy protocol, mainly you need a coronal sequence, especially the to look into the hippocampal region. Okay, so hippocampal region important. So tailor your images accordingly. Angled coronal T2 images, axial and coronal T1 images, flare, diffusion weighted and susceptibility images again in axial and angled coronal images, right? So guidelines as a headache, if somebody comes with the severe headache, the worst headache of their life as they describe in cases of acute hemorrhages or aneurysmal bleeds, that time you take a CT head first without contrast. If the patient comes with trauma, first again CT head without contrast, because all these places first you need to rule out is a bleed, okay, suspected without contrast. These three also, first three indications, you take a CT head without contrast, then you look into it. If needed, you go into the further MR sequence. But when a patient comes with acute neurological changes, focal stroke-like symptoms, MRI is a modality of choice. Okay, seizure also, first onset seizure. First you take a brain, then depending on the sequences, then you decide on the contrast. Sorry, I took a very, very long, exhausting session. Anyways, good day. Thank you. And you're open for questions.
Thank you so much for a wonderful talk, ma'am. Ma'am, we have few questions from the YouTube chat box. The first question is, how MRS is useful in tumors?
As I said, tumors, as I said, MRS, mainly it is to differentiate the grading from a high grade glial tumor to a low grading of the glial tumors. MRS becomes important. That is the main application there. Then anything else?
We have one more question, ma'am. Additional sequences used in multiple sclerosis.
There are many new sequences that is been now in the study for MS sequences, like you have 3D reformatted flare images that is coming up, 3D flare images, but sufficient flare images are very important in cases of MS, especially sagittal flare images. Okay, sagittal flare images, and you have your T1 contrast images also, T2 flare images, sagittal. And for MS, always remember, cover the optic tracts, optic nerve, and the spinal cord. They are normal. Always what we do, the sagittal T2 flare images. Optic tract and spine becomes important. Okay, and the flare images and post-contrast T1 images also you can take. And proton density imaging is also important. We can do on a day-to-day basis for MS sequences.
Thank you so much, ma'am. It was a wonderful talk. Now, over to you, Kelvin.
Thank you, ma'am, for the wonderful talk that you gave extensively on MRI brain. Now we'll move on to the next session. Next session, we have Mr. Manzoor Ali, who finished his bachelor's and master's in medical imaging technology from KSHEMA Medical Academy. He has 2 years of experience as MR technologist. Now he has 1 year experience as a teaching faculty, currently working in Father Mullers Medical College.
I myself Manzoor Ali, working as a lecturer and MR technologist at Father Muller College of Allied Health Sciences, Mangalore. I'll be discussing here about abdominal MRI, which one of the common MR in the department. And this also contains basic workflow, patient preparation, positioning, protocol, and pathologies. So let's begin with the basic workflow. Here I have divided the areas in the MRI into different. Uh, the reception desk, nurse preparation area, waiting room, and scan room. Next, the persons are also divided here. So there's we have the patient, reception staff, nurse, and MR technologists. Now let's see what this persons will do with respective the work areas. The patient will be arriving at the reception, then they'll be heading to the reception desk, then the reception staff will do the registration. So once the registration is done, the patient will be handed over to the nursing staff, and the nursing staff will take the patient into preparation area where they will do a screening. Screening will be done here. So there will be a screening form with multiple questions will be there, and the screening of the patient will be done here about the patient histories, etc. Then IV placement. If the patient is indicated for a contrast study, then IV placement should be done. So that will be done here by the nurse. So once this is done, then the patient will be going back to the waiting room. Here, the reception staff will notify the MR technologist that the patient is ready for the scan, and now the patient is there with the MR technologist, and the MR technologist will take the patient into the MR waiting room, and here there will be a screening will be there. So this is a re-screening. Patient will be re-screened here. The thing is that the patient will be taken to the scan room. So before that, we have to assure that the patient is okay for the MR scan. Rescanning will be done, and then we'll ask the patient here to change the dress into the hospital gown. So when the screening and the dress changing is over, then we'll take the patient into the scan room, perform the scan. After the scan, the patient can dress up and he can leave the department with the films, and the report usually it will be after some time. So this is a basic workflow in the MR department. Now, moving to the patient preparation, here appointment should be given. So need of this appointment is that the patient won't feel happy to wait in the radiology department. Even if they are waiting in the wards or the hospital room where they are or their home, they won't feel that much discomfort, but they'll feel a lots of discomfort when they are waiting in the department. NPO should be there 4 to 6 hours. This will reduce the ghosting artifact due to the peristalsis. Get the clinical history, which is very important for the radiographer to alter the scan or to do some special sequences or to concentrate on a particular area, and also for reporting. It will be helpful for the radiologist. And check the serum creatinine report if the patient is indicated for an contrast study. Patient preparation in the department. Here, we'll weight the patient. We have to check the weight of the patient, and that has to be entered for the calculation of SAR. So we'll enter the weight into the system, and system will calculate this here. Here, the next is that we'll ask the patient to wear a hospital gown. So patient had to change into hospital gown. We'll head the patient to the changing room. Here we'll ask the patient also to remove the metallic objects. Patient had to remove the metallic objects, and if any other objects are there with the patients, include the phones, keys, etc. Then a screening for the metal objects should be done. So these things will include the implants, pacemaker, prosthesis, denture, stents, etc. Next is that we had to take a consent. So there a consent has to be done. This consent should be written and informed and explained nicely to the patient. And safety questions will be here about like the history of any previous allergic reactions or the surgeries, etc. And once this is done, then the next is that in case of if the patient is indicated for a contrast study and there is no IV cannula, we can there will be the placement of IV cannula. So this is only for the contrast if it is indicated the contrast. And once a cannula is placed, you can check whether it is in the exactly in the IV or not. Next, in case if the patient want to contact with the radiographic technologist during the scan that the patient is not feeling good or something, we can give an emergency visit to the patient. And if the patient need to contact with the technologist, then the patient can use emergency visit. Breath-hold instructions and trials. This is very important that the sequences what we are using here for the abdomen will be with the breath-hold and without the breath-hold also. So there will be many sequences with the breath-hold action. So the breath-hold sequence is then we have to inform the patient. The patient had to hold the breath once we are giving the instructions. And after that, if you're giving a trial, it will be very good there. So you can ask the patient to hold the breath and you just check it that the patient is holding or not. So give a trial 1 or 2 times or 2-3 times. It will be better during the scan. Explain the complete procedure. It will take this much time and there will be sounds will be there and the patient should not move. So I'll explain those things. So when this is done, now we'll start with the we can start with the scan. Here, the patient positioning and central ray. Patient is positioned head first or feet first supine, and hand overhead or side of the trunk also can be kept. But it's always better to keep overhead to reduce the artifacts. A patient will be positioned over the spine coil, and over the patient there will be the abdominal coil or the body coil. And during the placement, this abdominal coil will be placed nipple line. The upper part of the coil will be on the level of the nipple line down to the iliac crest. And you can give the patient some cushions under the leg for the support. And the central ray, Cepheid process is a central ray. I will center over the Cepheid process and tight the coil. Now we'll move to the sequences. So always the scan will be beginning with a lock laser, a 3-plane lock laser, and after that T2 blade axial laser, and then a T2 FS blade axial laser. So one is FS and another one is just without FS. Then T1 by FS 3D coronal, T2 trophy coronal, and in phase and out phase axial, T2 in phase and out phase axial. Then T1 pre-contrast is 3 mm. Next is we'll give the contrast. Then a care bolus is which is for tracking the contrast. After that, T1 3 mm dynamic scanners. Then a delay is T1 same the T1 delay scanners. The delay will be varies according to the area of the interest. Usually for the liver it is 20 minutes and the pancreas is 5 minutes. Here I'll be using 2 types of sequences. That is a breath-hold sequence and triggered sequence. And there are some difference between both of them. Breath-hold sequence here, the patient has to hold the breath during the sampling. So when the scanner is going on, the sampling time, the patient have to hold the breath. And the next is that triggered sequence. So triggered sequence here, patient no need to hold the breath. The machine will monitor the respiratory motion and accordingly the machine will do the sampling. So if we want to, if the patient is good, and we can reduce the time to 20 seconds of some sequence and ask the patient to hold the breath. So that's a breath hold sequence. Or else if it is a 40 seconds, we can divide it to 10, 10, 10 like that. 4 times we can ask the patient to hold the breath. And once 10 seconds is over, then we'll ask the patient to leave it and calm. And after that again last hold. So this can be repeated. So they are the breath hold sequences. Right? So the first image shows the breath hold sequence. There is a normal planning only. There is nothing extra other than the slices boxes. But in the triggered sequence, you can see here a small box which is called as a navigator, and this will be placed half over the diaphragm and half over the lung, okay, half over the liver and half over the lung. So this will monitor the respiratory motion and accordingly the sampling will be done. Now we'll move to the workstation here. The first thing is that we are registering the patient. So during the registration, we have to enter a lot of some details here: the patient name and the patient ID, then the date of birth, and after that the gender. And once the date of birth we are entering, the age will come here automatically. Then the height and weight of the patient. So that is needed for the calculation of the SAR. We can see the all the bolded areas. This all the bold written area, they are needed to start the scan. Until we are done that, that is the exam option won't be. We won't get the exam option. So when that is done, then we have to select the study accordingly what we have selected. So all the preset studies will come there. So which one we want to do here, that we can select. So abdominal routine, which is I have selected here for the patient, and about the patient position, how the patient position, whether it is head first or feet first, supine prone, okay, how we are positioning. So here we'll be positioning the patient head first supine. So selected head first supine. When this is done, then we'll move to the exam. And here we can confirm that the patient name, weight, what is the position we are doing. Confirming here, now we are entered to the workstation. Here, the right side, we have the sequences. This all the sequence we are going to use here. So we'll be begin with the localizer first. Localizer with it's a 3-plane localizer. We'll get 3 images here: axial, coronal, and sagittal. And after that, so we got the localizer image. We can drag it to see here. And now we are planning the T2 blade sequence. So the anatomy was not covering, so I increased the slices to 30. And the axial, which had to cover from the superior part of the liver to the inferiorly the entire the kidney. So this is a planning, and so it has to cover from superiorly the liver and inferiorly to the kidney, and make it that the slices are perpendicular to the spine or vertebral body. So when that is done, here the FOV is a little bit anteriorly, so we can keep it down. And this is actually that navigator. Okay, navigator. This navigator had to keep half of the liver and half over the legs. Okay, so you keep it a little bit up here, and after that, therefore, we am keeping down. Now the area of interest is in the center of the FOV. So when this is done, we can apply. So this is a triggered sequence. The patient no need to hold the breath; it will automatically. So once we'll apply this, and after that, we have the next sequence. There is a T2 blade FS sequence. So what we have done is, what we have done here, it is a T2 blade. Next is a T2 blade FS. Before going to that, here what we have done currently, that is a navigator sequence, triggered sequence. Now we'll show you how we can convert this sequence into a breath-hold sequence. The same sequence, I'm keeping it down, opening here. Here a phase option is in the phase option, you can see trigger, breath-hold, and monitor. Okay, so here we can select how we had to how we had to do the scan. Okay, so we can select the breath-hold sequence. So once you're selecting the breath-hold sequence, then the patient had to hold the breath during the scan. Now heading the next sequence, that is a blade FS sequence. So we got the blade images. I can drag it here. So it is, so it's covering from the superior of the liver completely. That under the kidney is covered here. The planning of the T2 blade FS, it's same as T2 blade what we had done in the upper. Now it is T1 wipe 3D coronal sequence. So here covering the anatomy, and it is triggered sequence. Moving the next is another coronal, that is a trophy coronal, T2 trophy coronal. So this is a breath-hold sequence. We made it to triggered sequence. Navigate is keeping over the area, half over the liver and half over the lung area. Applying. And if we don't want to do that, then we can change that in the face area. Here, breath hold sequence we can select. Only selecting the breath hold, then there is no any navigator options. Okay. Now it is 39 seconds, which is a little bit difficulty for the patient to hold. So you can reduce the time. 39 seconds in a single breath is difficult for the patient to hold. So reduce the time with adjusting the parameters. So that will help the patient easy for holding the breath. If you can make the time some 20 seconds or 18 seconds, it will be easy for the patient to hold the breath. Now we are moving to the next sequence, that is the in phase and out phase. So it's an in phase and out phase. Here there will be two TE, TE1 and TE2. One TE is 4.76 and another TE is 2.39. So single sequence have two TE. About the sequences will be explaining later. The planning is same only how we are done it for the axial. All the axial plans are same here. So you can just copy parameters can be done here. And it's a breath hold sequence. So here you'll ask the patient to hold the breath, and after that I can press here. So the sampling will be doing. When the sampling is over, then I'll ask the patient to leave the breath and be calm. And after 5 to 10 seconds, again I'll ask the patient to hold the breath and again continuing the sampling here. So here I forward a little bit. And next is again we have a T2 sequence with the multiple TE, that is a T2 plus T2 TSC. Here are the two TEs. Then the T1 axial now. So the parameters is same here again. Sorry, the planning is same here, and it's a triggered sequence to keep the navigator over the area, and a diffusion sequence. So diffusion also axial. Here B value, the B value for what is here is 0, 50 and 800, and 3 B value is already here. And if we want to increase one more B value, the upper option is the diffusion weighting option. So there we can increase it, make it 4. So if you're making it 4, we can enter here what B value we have to add here. So accordingly we can add here the B value. So this situation we need only 3 B values, you know. So plan is same as the other axials. The FOB is not covering actually the entire area, so I'll just increase FOB here. So already 250, 350. Okay, 350 is little more, so you can reduce into a 320. Moving down, next is a T1 flash. It's a pre-contrast sequence. Axial pre-contrast sequence. It's a T1 sequence, and also it's a fat saturator sequence. FS sequence. So it's a 17-second sequence. 17 seconds is fine. That we can ask the patient to hold the breath. Now we open trophy here. This is a trophy image, and we'll check that whether it is covering the entire liver and the kidney or not. So a little bit kidney is cut here. So what we can do, we can increase the slices. Slice per slab, it's 40. Now we made it to 48. Yeah, it's covering now. So it's a breath hold sequence. Now it is 20 seconds. We increase the slices. That's it's become the 20 seconds. Applying here. Till this we have done the pre-contrast. Now we have a test bolus sequence here. Okay. So the test bolus sequence, you can see here how it's kept. It's over the heart, cardiac you can see. So what we can see the contrast is reaching there. This sequence have only one slice, and here you can see it is 1 minute. Total scanning is 1 minute. So one slice that's scanning 60 times. So each second we'll get one slice. each seconds will get one slice. The same areas will it will be repeating again and again. Now you can see the 60, if I'm reducing into 59, the time also will reduce to 59. If you are reducing it again to 58, the time also reduces to 58. So this measurement, you can see each sequence what is the time starting and ending. So we'll keep it 60 only. And after 60, we are applying that, but the scan won't run. Okay, we have to continue the annual scan run. Now the post contrast sequence, that is a dynamic sequence also. We get the planning is same as the axial, but the dynamic here you can see the measurements. Okay, so test borders we have seen that the measurement is 60 here. It means 60 times scanning. Now the scanning time is 17 seconds and the measurement is 1. It means how many slices is there with the sequence, that is T1 flash dynamic, that much will do, and after that it is over. If is increase this measurement into 2, then 2 times it will scan. 3 times means 3 times. Same area after 1 scan, it will scan 1 more time. 3 times, 3 times it will scan. Now there is an option is it pause after first scan, second scan, like that. Okay, so we know that CT scan will be all of them will be very familiar with that. In the arterial phase, venous phase, portal venous phase, there is some delays are there. Okay, so same technique we are using. Once we are tracked the contrast, that is with the test follow sequence, then immediately we'll start the scan here. Okay, so that will be the arterial phase. Now here, see if you're making 2 measurements. So after the first scan, that is the arterial phase, we'll keep a delay here, a 15-second delay. That is to start the portal venous phase. Okay, and now we are made it 3 measurement, that is a 3 scan. So after first scan, there is 15-second delay. After second scan, we can make it some more delay here. Okay, so you can make it 5 seconds. But if you're making it 5 seconds, there will be issue will be there. After once the second scan is finished, patient will get only 5 seconds to breathe the breath. Then patient have to hold the breath again. So it is there's a chance of movements in the next next images. So what we can make, we can increase the timing actually from the 5 to 8 or 10, something like that. Okay, so we'll increase the time to 8 seconds will be fine. Okay, 8 seconds. So that is done. So the total time is 1 minute and 15 seconds. This will include the scanning time, delay time, all those times. Approximately, if you are increasing the slice to 48, the scan time will be 20 seconds. Balance all is the delay time. We are applied. Now contrast is given continuously 1 second, 1 second. We'll get the scan. Okay. So little bit I skip here. So here we got the contrast. Okay. So here we got the contrast. Once we get the contrast, then press the stop button immediately and continue the next sequence. Immediately within 3 seconds, it will start the scan. So by the time we can ask the patient to hold the breath, the patient will be holding the breath. So once that is done, we'll get arterial, portal venous, and venous phase. Then we need a delay phase. So according to the time, how was that? What delay is needed? We can plan one more same sequence without with a single measurement. Only one in the scan will be there. Okay, so this will be planning accordingly that what is the delay is needed. So it will be varies with the patient's conditions or patient clinical history. Now we'll move to the in phase and out phase. This sequence we are using in the abdomen. Here, the proton in the fat persists slower than the proton in water. Both the protons in fat and the water, the precision is different. So one is slower, the fat protons are slower comparing with the protons in the water. So some points where the proton of fat and the water, they will align, and that is they are in phase. And there are some other points where the protons of fat and water, they will be opposed, and that is out of phase. When they are in phase, that means when they are aligned, that time the signals will be added, water plus fat. And when they are out of phase, they are opposed, that time the signals are subtracted. So this addition and the subtraction of the signal will be done when this are in a single voxel, when they are in a single voxel. The image here, the first one is an in phase and the second one is an out phase image. And easy understanding in the image is that surrounding the organs, abdominal organ, there is a hypointense plane we can see. It is an area where the fat and water is present. So that's why that area is hypointense. The signals are could cancel here, and we're getting an hypointense area, which is seen in most of the abdominal viscera, surrounding abdominal viscera, that the water contains in the organs and the fat in the abdominal cavity. The TE what we're using is 2.25 milliseconds for the out phase and in phase is 4.5 milliseconds. Now we'll discuss some pathologies starting with the HCC, hepatocellular carcinoma. In this case, here 4 images are there: T2, T1, and arterial phase and portal phase. Hepatocellular carcinoma, this will be hyperintense in the T2. Okay, so here it is hyperintense. Hyperintense means this is comparatively with the liver intensity. The lesion is hyperintense, and in the T1 it is hypo. It's hypointense. So the characteristic of this hepatocellular carcinoma in T1, it can be hypo or it can be hyso also, or very rarely it can be hyper also. Hyper is actually due to that intratumoral fat will be there. So that time those will be look like hyperintense. All other conditions it will be completely hyper. But T2 is slightly hyperintense. Then moving to the arterial phase, the main characteristic of this HCC is that they will be enhancing in the arterial phase, early arterial phase. They will be enhancing with the early arterial phase and wash out immediately. So the first one, so the D, this is a this picture is actually the arterial phase, which shows an enhancement of the lesions. Where here, this one here enhancement is not there, which is a portal phase. So immediately after the arterial phase, there is a washout visit. So this is a characteristic of the HCC. We'll see one more HCC here as a T2 weighted image shows a slightly hyperintense. Diffusion restriction are seen. This both are the diffusions. B and C is the diffusions. Slightly restrictions can be seen here. After that, the D is an arterial phase, which shows enhancement of the contrast. Then late into the portal phase and the delayed phase, there is no any enhancement, but there is surrounding enhancement as seen. Surrounding enhancement is it, but the lesion is completely hypointense. There is no any enhancement, so that's a washout. Moving to the next, hepatic hemangioma. Here we have the 4 images: T1, T2, arterial, and delayed phase. Hepatic hemangioma, they are hypointense relatively to the liver parenchyma. So in T1, they are hypointense relatively to the liver parenchyma. Here the lesion is very hypo comparing with the liver parenchyma, and the T2 it will be hyperintense, and that's related to the liver parenchyma. It will be hyperintense, and also this intensity won't be that much hyper like the fluid or the CSF, etc. It will be less hyper comparing with the CSF. Now we are moving to the next here, arterial phase. Arterial phase shows no any enhancements. So the lesion you can see it's completely, there is no any enhancement, but there is some peripheral enhancement is it. So the main characteristic of this hepatic hemangioma is that there won't be early enhancement in the artery, or there won't be any early enhancement. So after the contrast, the enhancement usually will be seen 5 minutes or after 5 minutes. Now this is a delayed image which shows there is enhancement is seen in the delayed image. So the characteristic is that hepatic hemangioma enhancement is contrast enhancement is seen in the delay images. Now we'll move to the next one, that's a hepatocellular adenoma. Here A is a T2 weighted image which is hyperindence, and B is a diffusion weighted sequence. There's a restrictions can be seen, and the T1 pre-contrast non-enhancement is isoindence. Then the D is a post-contrast arterial phase. There is an enhancement is in, and after that the portal phase enhancement is reduced, but still a little bit, but it's reduced. And after that the venous phase there is no enhancement. So hepatic adenoma here, the appearance, the T1 appearance can be variable actually. So T1 it can be usually it will be hypoindence, but there is a chance for iso also, but it can be vary here. And the T2 is will be mildly hyperindence. T2 will be hyperintensity. Diffusion restriction will be there. Then the contrast arterial phase enhancement can be seen. So in this case, hepatocellular adenoma, arterial enhancement can be seen, and there is no any enhancement in the delayed phase or the venous phase. That's all. So finished. Thank you, and I would like to thank the organizing committee for giving a chance to speak here.
Thank you so much, Manju, for such a wonderful talk. We have few questions in the chat box. The first question is, MR pancreas without and with contrast protocol is preferred in which all cases?
Okay. Okay, so contrast in MR pancreas. So here, what is any carcinoma cases or any mass lesions are there? So those are the cases the contrast is indicated. And the next is that the cases like acute pancreatitis. So here we had to look for the necrosis of the parenchymal necrosis and the parenchymal enhancement we had to see. So these are the cases we will do the contrast studies for the pancreas. And non-contrast studies, we once if you want to see the PD or any tactile anomalies, etc., we'll go for the non-contrast MRI.
Second question is, Manju, for you is, if the patient is not cooperative, can we use a trigger technique?
A trigger technique we can use if the patient is not able to hold the breath. We can use a trigger technique, but still there are some limitations. If the patient breathing is not in a uniform format, which is altering a lot of things. So what happens if the sequence with the trigger, if it is just 2 minutes or 1.5 minutes, and if the patient's breath hold is not in a uniform way, which can lead to for 5 minutes, and also with some artifacts will be there. So patient cooperation is important. At least if the patient is the breathing pattern is in a uniform and normal pathway, then it is fine.
One more question was asked by Sia Tanwar. Difference in image quality in triggered sequence and breath hold sequence.
Yeah, breath hold sequence will get a better image quality comparing the triggered sequence, which actually I felt in this experience. And so it's always better to give the breath hold sequence. But the issue is what happens if the patient is not able to hold the breath properly. That case, if you are taking a breath hold sequence, the quality will be bad. So those are the cases we can go for. Even the trophy imaging sequences are good, like it will capture very fast. So what happened that movement will be less, that respiratory motion will be less, and otherwise we have to go for the triggered sequences. So if the patient is able to hold the breath, then always it is better to go with the breath hold sequence.
Thank you so much, Manju. Over to you, Kyle.
Thank you.
Thank you, Manju, for a very informative talk. We got a lot of appreciations for your talk as you were talking. Next, we have Mr. Mohammed Siar. He finished his bachelor's in MIT from KSHEMA Medical Academy, and is immensely passionate about, particularly in MRI. He has 2 years experience as a technologist, and currently is working as a technologist in Astor RV Hospital.
Hi, good afternoon, everyone. My name is Mohammed Siad. I'm a radiology technologist working in Astravi Hospital. So, first of all, I would like to show my sincere gratitude for providing such a beautiful platform to talk on such a sophisticated and interesting topic, fMRI. So, before we get into the session, I just need to make sure, like, whoever is viewing the session, should be aware of, the main difference between MRI and fMRI. So when it comes to normal MRI, it's nothing but we're just acquiring the images of anatomy or different structures of body in different planes and in different contrasts using different sequences. But whereas when it comes to fMRI, still we are acquiring the images of metabolic functioning of your brain. Okay, so metabolic function we get in the form of activation. Okay, so I'll get into that, like how even it happens. So say for example, when you do certain activity in the sense, like say when you think of something, or when you see something, or when you tap your fingers, or when you move your foot, or like whatever. So when you do these certain activities, there are different centers or different region in your brain which controls these different activities. So at a point of time when you are engaged in a specific activity, there is a specific or particular region in your brain which controls that activity. That region gets activated. Okay, that activation is what we call as metabolic functioning. So this metabolic functioning we see in the format of activation. So this is basically all about what fMRI is. And so as an introduction, fMRI is introduced in 1990s. fMRI is a non-invasive technique for imaging the activation of brain areas by different types of physical sensations, such as I already talked about sight, sound, activities such as movements. And fMRI uses same basic principle of atomic physics as MRI scans, where MRI scans normal on image anatomy structures, and whereas like fMRI image metabolic function. It's a non-contrast imaging technique in the sense, like when it comes to a normal MR, when you get to see some kind of lesions or get to see enhancement, usually we go ahead with gadolinium contrast agents for the further enhancement. But here, see, you can see that yellowish structure within that image which you are given. That yellowish structure which we are getting not because of any contrast agent, but normally in routine MRI to see the enhancement of any lesion we give contrast agent. But here in fMRI, that activation what you get in the region of brain, that is mainly because of the blood perfusion to that region, or the what we call oxygen content present within that blood. So it's also known as a bold imaging, blood oxygen level dependent. So that's very important. See, blood oxygen level dependent in the sense, see, whatever the activation you get, okay, because of any activity, that is purely based on blood oxygen level dependent. In the sense, okay, I would like to talk about this with an example. Okay, suppose when you are tapping or moving your finger, see there's a specific region in your brain. You could see in the slide, I mean image which I have given. See, that is kind of superior parietal region of the brain. Okay, in superior parietal region of the brain there is something called precentral gyrus, or kind of precentral sulcus. So this precentral sulcus or precentral gyrus, which I've shown, just a minute, I'll show that. Okay, see, you could see here, this is basically precentral gyrus region. So this is the region in your brain which controls the movement or tapping of your finger. So when you tap your finger, this region in your brain called precentral gyrus is getting more quantity or more volume of the blood compared to the other parts of the brain. Okay, so this, what I'm trying to say is that like this region is getting high perfusion compared to other part of the other part of the region of the brain, at that specific point of time because of that specific activity, that is tapping of fingers. So basically, the arteries which supplying blood to that region gets dilated. Okay, more quantity of blood flow to that region. So more quantity in the sense, we know that fresh oxygenated blood. Okay, so oxygenated blood is nothing but it's oxyhemoglobin. We have already learned MRI basic principle of physics, whatever. Like this oxygenated blood is nothing but it is diamagnetic in nature. So if something diamagnetic, if it comes in the vicinity of main magnetic field or our B0 static field, ultimately it produces signal. Okay, so that signal, okay, is what we see in the form of activation in this yellowish color. So I repeat, since it's very important. So we are engaged in activity, that is, currently I'm talking about tapping of finger. So when you tap your finger, the region which controls this activity is precentral gyrus of your brain, that is we have marked in this red. So that region is getting high quantity of blood compared to other part of brain. So high quantity of the blood in the sense oxygenated fresh blood. Okay, oxygenated fresh blood, that is oxyhemoglobin, which is diamagnetic. So if it comes in the vicinity of main magnetic field, ultimately it generates signal, and that signal we see in the form of this yellowish activation. So that is basically what we call as metabolic function. So I told I mean, fMRIs, I mean, this imaging basically, blood oxygen level dependent, because, this is purely dependent upon, I already told, amount of oxygen, or blood is carrying oxygen. So how much ever, oxygen reaches that region, that much activation can be seen. So for a specific activity, the region which controls that region gets more blood, more oxygen. So this is purely dependent upon blood oxygen level, okay, which ultimately reaches to that point of brain. That is why fMRI is also known as blood imaging. And so I already talked about blood oxygen level dependent, like how it works, practically within. And it's area of brain that are more active tend to receive higher level of oxygenated blood than surrounding. I told that like when we are engaged in an activity, the brain region which controls that activity is getting higher level of oxygenated blood. That is the principal reason behind. And oxygenated blood is diamagnetic, but deoxygenated is paramagnetic. That's very important. Like you know uh, the other part of region, the other part of brain, which is not engaged in activity, would be in kind of paramagnetic in nature, because already when we are involved in an activity, the brain region which controlling that activity, it's getting hypofusion, whereas surrounding region of the brain which is not engaged in activity, we can consider it as paramagnetic in nature. Okay, so we know that when something paramagnetic is in the vicinity of our static main magnetic field, okay, ultimately the hydrogen photons in that region dephases. Okay, dephases in this sense, like signal loss, no signal. That is the reason why you have seen the previous slide, only the region which controlling the activity of the brain is getting activated because of oxyhemoglobin diamagnetic. The surrounding region which is not getting which is not engaged in any activity because of that paramagnetic nature, so dephases, no signal. And since blood oxygen varies according to the level of neuronal activity, these difference can be used to detect brain activity. That's basically bold imaging. And bold imaging requires continuous and rapid scanning with high temporal resolution, and this is very important. We just need to make sure that temporal resolution is really good, because like patient shouldn't be moving at all, because even the slightest of any other movement would would affect the resolution, temporal resolution of the image, and its sensitivity to T2 star effect. That's basically, I mean, our paramagnetic thing. and images are acquired with single shot. Feel like echoplanar imaging. We are using echoplanar imaging sequence means we need to finish off the scan at earliest, so time should be minimum. So echoplanar imaging is nothing but we are acquiring or we are filling off the signal in all the lanes of K space in a single TR, so that like we could reduce the time of scanning. That's all about blood oxygen level dependent. And so first, yeah, given the graph of blood oxygen level dependent response. So for better understanding, I would like to link it up with practical stuff what you do. Again, see, when we are engaged in an activity, again I would like to go with same example since I've been talking with the same. So when you're tapping your finger, the brain region which controls this activity is precentral gyrus region in your parietal region. So that region is getting high amount of oxygenated blood. Okay, so when the perfusion of oxygenated blood increases particular to that region, oxygen content increases. That is described in the form of graph here. See, it has reached its ultimate. Okay, so when someone is engaged in that activity, that region is getting more and more oxygenated blood. That is what this peak indicates. And when you stop doing that activity, again this graph comes back. See how here it again comes back. So when it comes to practical, okay, we'll ask the patient to do activity. So when we ask the patient to start doing, okay, patient would be, say for example, again patient would be tapping his finger, so that graph goes up because of high amount of perfusion to that, that particular region, oxygen blood that region. Then after a certain period of after some 10 to 20 dynamic scans, we'll ask the patient to relax. When patient relaxes, blood flow to that region stops, because since patient has stopped that activity, that's why it again comes back. So after a certain period, like when we ask the patient to again start activity, or again when patient taps finger, again flow to that region increases, then it would come up again, like it would come up again. Then patient relaxes after certain dynamic scan. And ultimately when scan gets over, you take average, system does all stuff like, ultimately you take average of all these peaks, and after kind of processing happens inside, ultimately we'd be getting that activation which you have seen in yellowish color in that previous slide. So that's all about how, importance or significance of blood oxygen level dependent, and like how blood oxygen level dependent response graph occurs. Then comes to, so we'll get brain stimulation. We know that brain has got what we call different functions, and it controls different activities of it's kind of main center, we could say. So now we already talked about basically what is fMRI. Okay, I just need to make sure like at least by the end of the session you people would be getting at least an idea of what is fMRI all about. So for that, okay, whatever activity you do, there are certain region in your brain which controls this activity. So I would like to talk about some of the activity and the respective regions in your brain which control that activity. So basically when it comes to hand movement, I've been talking about only hand movement. Okay, so hand movement is controlled by precentral gyrus. That is like you have seen already, but still suppose this brain, it would see like this is precentral, this is central. So this is the region which controls what we call precentral gyrus, sorry, hand movement. So like you might have seen almost superior most parietal region, there would come something like fox cerebri. So this is where is this is what basically paracentral precentral gyrus region. You could see small structures like this. This is the region which controls our foot movement. Okay. Okay, this is foot movement, and this precentral gyrus region controls, our hand movement, and many more, like, our temporal. So you can see in this image, our temporal, this is our temporal lobe. Okay, so in temporal lobe, temporal lobe is basically for, hearing purpose. And see, this posterior most temporal region, which controls, you can see, that is also known as, vernix area. You could see here vernix area. Vernix area controls, generation of speech. And, inferior posterior region of frontal lobe, that would be almost here, controls, our, what we call sentence formation. In sense, see, when you hear something, like, when you hear any word, suddenly, immediately, some kind of thought is getting generated in your brain. Okay, so basically these kind of stuffs are controlled by, vernix and broca's region. And temporal is, usually what we call, generally, controls hearing. And when it comes to occipital lobe, which controls vision, like, you're seeing something, and that signal goes via, optic nerve, then, optic chiasm, then optic disc, and optic radiation fibers. Those are fiber bundles, and ultimately signal reaches this occipital lobe. And, memory is controlled by something like hippocampus. And, complicated decision making by, frontal lobe. And it goes on. So that's what, different activities, whether it's motor, sensory, it's controlled by, different parts of brain. So if you give, okay, during time of fMRI, if you ask the individual to get into any activity, if you give any task, uh, that region in brain which controls this activity, because of hyperfusion to that region, gets activated, and that activation can be seen. So these are some of the, main brain stimulation region. But I would say when it comes to, clinical setups, these 4-5 are, main activities which we give to the patients, like hand movement, foot movement, and speech, sentence, and, vision, etc. And next, so when it comes to clinical applications, okay, so far we have discussed, what is fMRI, and how do we get, fMRI activation, what is the principle behind, then what are the certain, or in the, specific regions in your brain which controls, different activities, what we do, day-to-day life. But still, you people would be having question, why fMRI? What is the use of fMRI? What is the reason behind, here we are doing, fMRI? Okay, I would say, it is used in, clinical psychiatry, then for research purposes, mainly to see, like proper activation. When you do that, when you do this, how blood, respond, how brain responds to that. But when it comes to, clinical or hospital setup, I would say, with my experience, it is usually used for pre-operative, planning on surgical resection. In the sense, okay, you could see that, like, I've given image over here. So this patient has got a lesion in, kind of superior parietal region, like, yeah, you could see here, see, kind of lesion is present here. So surgery team has planned to, remove of this lesion, okay, surgically. So they're kind of confused, like, okay, so that, see, this is the region, almost, okay, okay. So sometimes it could be over here, sometimes, it could be over here, okay, okay. So it could be almost over any of this region, okay. This is the region basically what controls your foot movement. So surgery team just needs to make sure that, okay, because of surgery, okay, by mistakenly, when they are removing of this lesion, okay, the proximity region, like, nearby region, okay, which is controlling that patient's, foot movement, shouldn't be damaged, okay, it should not get damaged, okay. So I already said that, the foot movement, okay, can be controlled by parasitical presynaptic sulcus region, but it could be almost anywhere over here, or sometimes this region, or sometimes this region. But we know one thing, lesion is present here, right? So after doing fMRI, by giving the patient task of what we call tapping of fingers of foot, or movement of foot, okay, will get to know where exactly in that specific patient the activation is happening, in the sense when that patient moves his foot, okay, where exactly the activation is happening, so that by finishing off fMRI, doctor would be having an idea exactly which is the region controlling, and like is it in close proximity to the lesion, or is it away from the lesion. If it is in close proximity to the lesion, that is really kind of complicated scenario for surgery team, because if it is close proximity, okay, what we say, the resection of the lesion would ultimately end up along with deficit, or issue with patient's foot movement, okay, by mistakenly it can happen. So they have to think of an alternative way. So I would say this is the significant thing what we see in clinical setup, that's pre-operative planning, okay, before we take the patient for surgery, just to make sure surgery shouldn't be harming any other sensory or motor sorry. Then, and for fMRI, basically the sequence used is gradient echoplanar imaging, and because like we need to finish off the scan at earliest. So we know that like how in MR we get signal. Once we get signal, that signal has to be deposited in something called K space. So how long it takes for the filling up of K space, ultimately tells that like how long scan would be. So if you would finish off the filling of K space at earliest, you could finish off scan 2, so that echo planar imaging is basically we could fill off all the space, or all the lanes of K space in a single TR. And we don't want we want better temporal resolution, so that scan time should be reduced, so that we're using in a shortest T. So when it comes to 3 Tesla, T of 35 millisecond, and in 1.5 Tesla, T of 40 to 50 millisecond. And when it comes to workflow, that's patient preparation and positioning, there is no much difference, like same as how we do with normal routine MRI brain, same positioning. And the important part is patient preparation is instructing the patient, because like patient is not aware of what is fMRI, okay, and what's happening in fMRI. So we have to educate the patient actually about like what's happening, saying that this is to see your brain activation, or this is to see how your brain responds to different activities. So this is the issue, and we are giving you this kind of activity. So when we give you a certain activity, you should be only following and doing that activity, nothing else, because like if you do something else along with, even that would bring activation to the brain. So at a point of time when we want to acquire a specific activation of a specific activity you do, you should not get engaged with any other activity. And when we ask to when we say start, you just start doing the activity. And when we say relax, just stop doing, just make your mind or like everything else void, nothing else other than that. And along with ensure that head is stabilized to prevent movement, that's already told, because to get proper without any movement artifact for better temporal resolution. So the main part is educate the patient regarding what the study is all about, what is the importance of study, and that's all about patient preparation and positioning. So now I'll take you through a video, I'll show like how we do fMRI, and like how we post process to eventually ultimately to get that image with activation. So to start off with, localizer, Then our department we usually do in such a way that we acquire a log laser, then a 3D flare or 3D tune, whatever, then FMR sequence, because we know that like usually with FMR image, SNR would be reduced, so it would be difficult to differentiate anatomy properly. Sorry. So we'll merge FMR image with 3D image, so image quality would be better. I'm starting off with survey. So once we get survey, I'll plan 3D flare on survey. After getting 3D flare, I'll plan FMRI on flare image. Yeah, this is our flare image, 3D flare. So I'm planning FMR image, FMR sequence on flare sequence, flare image. And it's normal planning, like normal axle planning we do for MRI brain. And you could see that in parameters, see fast imaging mode, that's echo-planar imaging, where you could finish off easily in a single tier. You could fill off all the key space. Here I've chosen 80 dynamic scan, that's shortest. 80 dynamic scans is nothing but first 10 dynamics would be relaxation, resting phase. I wouldn't be giving any activity to the patient. After 10, next 10 would be giving any activation, depends individual, depends the case. If it is kind of verb and sentence, I'll give some random words to the patient. Patient should be thinking of those words accordingly. Generation will be happening. Same with tapping fingers, whatever. So after planning FMR sequence, so you'd get this. They ask prior to start scan. See, dynamic scan has been started. So you could see performing dynamic scan on. So scan has been started, and this is basically relaxation. I'm not giving any task. After it reaches some 10 dynamics, I'd be giving the task. Task in the sense like in this I've done with my colleague. I've given the task of some random thoughts. You should be thinking of the words. And when he thinks of the word, we know that usually verb is getting generated in Broca's region. We'll see how it goes. Okay, now it's dynamic level and started, so I'm giving task. See, I'm giving him random words like mother, father, hospital, etc. So he has to think of that word. Okay, I'm explaining. Vehicle. When he thinks of that word, that region which controls that activity is getting more amount of oxygenated blood. That is ultimately what gives us signal or that activation in yellowish color. Hospital. We'll see that. See, 20 dynamics got over. So this is just few part have shown. So after scan gets over, yeah, our FMR sequence got over. Now I'll show you how we post process. See, this is the FMR image with less SNR. That's why we're gonna merge this FMR image with our previous flare image. That would give better image. So just right click, and the software we have is iView Bolt. That's Bolt. See, blood oxygen level dependent. Okay, click on that. Then you'd get this window of post processing of FMR. Then let's see different options like compute. See, use sequential image, where you could add or merge our previous flare image. See, I'm choosing actually flare image. Okay, then it's getting merged. Oh, it got merged. So now I'll post process on this flare image. Our FMR image has been converted to flare. Okay. Now see, suppression. Suppressing the motion, because like along with normal proper activation, some kind of artifactual activation would be there. By making on, you could eliminate such artifacts. Then compute option. With that compute option, see our FMR image is getting post processed. Once this processing gets over, you could see the signal. See, now you could see the signal in yellowish color. So you already seen that I have given the task of he has to think of these different words, random words. So it depends. In some individuals, both the sides, both the Sylvian sides or both the Broca's sides would be getting activated. But in this particular individual, when he had thought of those words, see, his right side Broca's region is getting activated. Just a minute. See, right side Broca's region is getting activated over here, and this is T score. This is T score. By increasing T score, you could reduce artifactual activations. So that's all about, like, you finish off the sequence, right click iView bolt, then you could suppress or eliminate artifactual activation. And you could see here, see dynamic scan, see 10 20. In first 10 I had given nothing, just relaxing, then 10 activation or because of activity. See, this is board oxygen level dependent graph where you could see spikes. So ultimately, like after some 80 dynamic scans, system would take kind of average of all the activities and eventually give us this yellowish color activation. So that's all about how we perform and how we post process fMRI. And we are at this final slides of the workshop or presentation. So now we have already discussed what is fMRI, what is difference of fMRI from a routine normal MRI, and how it works, the principle behind fMRI, and something like the clinical purpose, why do we do fMRI, and I've shown you the video of like how do we do, and eventually how do we post process, and how do we see the signal. And no, I would like to take you to the some of the cases which we had got from our department. And this picture I already seen in first slide. So hand movement, it's nothing but, see, this patient had some kind of lesion. So prior to what we call surgery, we have done fMRI for this patient, and you could see the activation of his hand movement is slightly anterior to the lesion. So that's kind of positive sign for the surgery team. And this is another case where patient, you can see that patient has got lesion in right side of parietal region. And like when surgery team was kind of confused with like whether it would be affecting his foot movement. So we have done fMRI for motor, like especially for foot. So we had asked the patient to move foot during the time of scanning, during the time of an activity phase. So after post processing, you could see that the foot movement is controlled by this parasietal central gyrus region, but it is slightly lateral or away from the lesion. This is also fortunately a good sign. And this is another interesting case where, say, you could see patient has got kind of large lesion in right sylvian region, and we know that vernix region is mainly controlling patient's thinking ability. So we just need to make sure that which side of this patient's brain is controlling his thinking ability, whether it's right or left. So we had given this patient random words to think of. So after post processing, even this is really good sign. Say patient has got lesion in right side of the brain, but in this individual his thinking process is mainly controlled by his left side. Okay, see activation in left side and lesion in right side, which means the probability of getting damage to his thinking process, it's really less with surgery. And there is another case of vision, and in this case, patient has got lesion in inferior occipital lobe, and we know that occipital region, occipital lobe controls, our, eyesight or vision. So patient has got, lesion in inferior occipital lobe, but you can see that post fMRI, and I mean, activation is happening, slightly superior to the lesion. So in this patient, like, the task what we had given is, I mean, patient was on couch, and we kept a mirror like in front of the patient, and passed a torchlight to the mirror, and he has to roll his eyes, wherever the torchlight goes. And ultimately, in the post processing with CC, the occipital lobe is getting generated. And okay, just a minute, not shown. See, occipital lobe is getting generated, and I mean, in this patient, lesion is coming slightly inferior, but the generation of the signal is kind of superior to the lesion. So again, another good sign. So this is all about some of the different cases I've shown of hand movement, foot movement, thinking, vision, etc. So yeah, that's all about fMRI. So we have discussed what is fMR, then the principle behind, and how we do the post processing, and the significance in the clinical setup, and like how we see that, etc. And now again, I would like to show my sincere thanks or gratitude towards the organizing committee of this workshop, Nitte Medical Imaging Technology. And also I would like to extend my thanks towards our manager of radiology department, Mr. Said Azmatullah, then our HOD and neuroradiologist Dr. Ravindra Bikamlo, who's been constant support. And yeah, my lecturer back then at KSHEMA Medical Academy, Skyle Viji, and he's been there since I started radiology journey, and I'm much indebted. And thanks for the invitation. And yeah, that's thanks.
Thank you so much, Siyat, for such an informative talk. We have got plenty of questions. We have chosen few of them. The first question is, what is the best way to identify the motor cortex using fMRI?
See, basically, I mean, motor cortex, or like whatever the, movement activities when patient do, it is getting activated or it's getting generated in the, superior parietal region, and predominantly in precentral gyrus, and sometimes in precentral sulcus. And most of the times we give tasks such as, lip movement, then something like tongue movement, foot movement, tapping of fingers. But basically, it happens within precentral or sulcus regions. Sorry.
Second question we have for you is, why do we use echoplanar imaging method for MRI?
Okay, I think I already explained in a slide that, see, in fMRI, we need to finish off this scan at earliest. Okay, so we know that the scan time is mainly determined by something called, how quickly we fill off the case space. Okay, so by using echoplanar imaging sequence, you can fill off all the lanes of case space in single TR. So when we fill off in single TR, it like rapidly finish off the scan or sequence. That's why we're using echoplanar imaging.
We have one more question for you.
Yeah.
If particular area supposed to get activated during the task and does not get activated, it represent what?
See, it is purely depends on how patient cooperates. Okay, that's what I talked in the where patient preparation. Patient should be properly. If patient properly follows our instruction, so that like proper flow of blood can be expected to that region, so that activation can be seen. If patient doesn't follow the instruction properly, I mean, probability of getting signal is less, so that we need to repeat. Yeah, that's all.
Last question for you.
Yeah.
In GE, which sequence we use for bold?
G, if I'm not mistaken, I believe GE bold. Yeah, GE bold. Yeah.
Thank you so much, Siad. Over to you, Kyle.
Thank you, Siad, for such an informative talk. Now, I would like to actually thank all the speakers who made today's session very successful. The feedback link will be given in the description in the YouTube chat box. YouTube, in the description box, you can find. It will be open for the next 15 minutes. And I would like to call Mr. Jasimuddin to give the vote of thanks.
Okay.
Very good afternoon to one and all. Honorable Organizing Chairman, Dr. U. Raghurat sir. Respected Organizing Secretary, Mr. Shashi Kumar Shetty, Coordinator, Department of Medical Imaging, and all the guests and the delegates. It is my privilege to have been asked to propose vote of thanks on this occasion. First, I would like to thank on behalf of Nitte University and behalf of my own behalf, extend my thanks for all guests who have been the part of this workshop. First day we had about radiography, Dr. Harshit, Mr. Maheshwari Naik, Ms. Rakhi Naik, and the second day we have CT modality, Dr. Vaishali, Ms. Amita, and Ms. Kavita. And on today's Niriksha Shetty, Mr. Mansoor, and Mr. Muhammad Siad. I would like to thank behalf of Nitte University and behalf of myself. I extend my thanks, and also I would like to thank our Dean, P.S. Prakash, Dr. P.S. Prakash, and the Vice Dean, Dr. Jayaprakash Shetty, for their immense support for this program. And I extend my thanks to IT support, Mr. Mahesh and team. And for all delegate, I extend my thanks. Thank you, all of you. Thanks a lot.